All right, welcome to this explainer. I am so glad you're here. Look, if you're a postgraduate medical student or an anesthesiology trainee, you already know the deal. Managing a severe burn patient, it's easily one of the most high-stakes, physiologically demanding challenges you are ever going to face in your career. We're talking astronomical risks, multi-system failure, and a patient whose very biology is rapidly changing literally hour by hour. So let's just dive right into this and unpack exactly what we are up against.
There's a quote that perfectly captures this. It's like a fire has been lit inside the entire body. You've got to completely strip away this idea that a major burn is just a localized skin injury. It absolutely isn't. Once a major burn happens, especially if we're talking about more than 15 to 20% of the total body surface area, it triggers this devastating, systemic inflammatory response. Every single organ system, every fluid compartment, every metabolic pathway, it is all thrown into absolute chaos. So here is our roadmap for today. We are going to cover Phase 1, acute resuscitation, Phase 2, perioperative challenges, Phase 3, chronic management, and finally, Phase 4, the marathon of burn pain.
Let's jump straight into Phase 1, acute resuscitation.
The very second that patient hits the trauma bay, the immediate life threats are front and center. And the decisions you make in these first few hours, they will literally dictate whether this patient survives. They essentially enter this incredible physiological two-act play. In the first act, which we call the ebb phase, lasting for those critical first 24 to 48 hours, the patient enters burn shock. Basically, everything just shuts down. Cardiac output can plummet by up to 60%. Blood flow to vital organs drops drastically. But then, almost like a switch flips, the body completely changes the script and enters the flow phase. Suddenly, the patient is in total hyperdrive. You've got a hypermetabolic state, hyperdynamic circulation, a raging heart rate, massive protein breakdown. Managing these two completely opposite extremes is an absolute masterclass in clinical balancing.
So what do? You fall right back on your primary survey, the good old ABCDE protocol: airway, breathing, circulation, disability, and exposure. Why is this so critical right now? Because massive edema is about to set in. As fluids start shifting, the soft tissues in the airway can swell so rapidly that an airway looking totally fine right this minute could be completely obstructed and virtually impossible to intubate just hours later. It is a terrifying race against time.
You've also got to actively hunt for those insidious signs of inhalational injury. We're looking for singed nasal hair, facial and mouth burns, carbonaceous, sooty sputum, hoarseness, wheezing, or any disturbed consciousness. If a patient was burned in an enclosed space or shows any of these signs, you absolutely have to suspect airway involvement and carbon monoxide poisoning. This demands early intubation. You want to secure that tube way before the airway becomes an absolute nightmare.
17. Think about that for a second. That is the staggering number of liters of fluid a 60% burn patient might require in just the first 24 hours alone. Once the airway is safe, your next massive enemy is burn shock. That systemic inflammation we talked about, it basically turns all the body's blood vessels into leaky faucets. Plasma just pours right out of the bloodstream and into the tissues, literally starving the organs of oxygen. To fight this, we use the Parkland formula, typically 4 milliliters per kilogram per percentage of body surface area burned, just to calculate this absolutely massive fluid requirement.
But here is where the hard science meets the true art of clinical judgment. Those formulas, they're just starting points. If you blindly pump in fluids, you risk massive fluid overload, which can convert partial thickness burns straight into full thickness burns and cause extremely dangerous tissue edema. You have to fine-tune that fluid flow literally minute by minute. And your gold standard for guiding this? It's urine output. You're aiming to hold a strict urine output of 0.5 to 1.0 milliliters per kilogram per hour in adults. That is your proof that the organs are actually being perfused without you flooding the entire system.
Moving right along to Phase 2, perioperative challenges.
So if the patient survives that acute shock phase, they're heading straight to the OR for early excision and grafting. Welcome to the OR furnace. Remember, without the protective barrier of their skin, the patient's internal thermostat is completely broken. To prevent fatal hypothermia, which, by the way, leads directly to coagulopathy and cardiac arrest, the operating room itself is cranked up to a sweltering 80 to 100 degrees Fahrenheit, or 24 to 27 degrees Celsius. It's hot. On top of that, you are actively warming IV fluids, you're trying to manage incredibly rapid blood loss, which easily hits 200 milliliters for every 1% of body surface area excised, and you're fighting altered drug responses because of crazy fluid shifts and changes in protein binding. It is a uniquely intense, chaotic environment. But right in the middle of all that chaos, let me ask you something. Every anesthesia provider has to know the answer to this. Why would a routine, totally everyday induction drug suddenly become fatal in a burn patient?
The answer? Succinylcholine. This is a literal deadly trap. Look, succinylcholine is a muscle relaxant we use safely every single day in normal patients, right? But if you give this drug to a burn patient more than 48 hours after their initial injury, it causes this massive, sudden release of potassium from all the upregulated receptors in their damaged muscles. This lethal hyperkalemia will instantly stop their heart. Understanding this 48-hour cutoff is not just some fun academic trivia. It is exactly what separates life from death on your operating table.
Okay, let's fast forward a bit to phase 3, chronic management.
Months or sometimes even years later, these same patients return for reconstructive surgeries. But they bring a completely new set of challenges, mainly distorted anatomy. As those severe burn wounds heal, they form this incredibly thick scar tissue and post-burn contractures. If you get these contractures on the face or the neck, the mechanical pull of that fibrosis can literally distort the airway. It creates an anteriorly fixed larynx. What this really means for you is that an airway that was a breeze to intubate on day 1 becomes this progressively horrifying nightmare to secure over time as the scar tissue tightens.
So how exactly do we outsmart this distorted airway? Well, first off, anticipate extreme difficulty every single time. Take 0 chances. Very often, your safest route is an awake nasal fiber optic intubation. You absolutely must avoid deep sedation before that airway is secured, because if they stop spontaneously breathing on you, you might never get it back. In some extreme cases, the surgeons will actually need to physically cut and release the scar tissue under local anesthesia before intubation is even physically possible. For that, ketamine is an absolute game changer. It gives you potent analgesia but beautifully preserves the patient's crucial airway reflexes.
Finally, we arrive at phase 4, the marathon of burn pain.
Post-op recovery and rehab for burn patients is, well, it's considered some of the most excruciating pain a human being can experience. You can't just throw standard painkillers at it and hope for the best. You have to fundamentally understand their specific pain profile. Burn pain actually has 3 very distinct layers. First, there's the constant grinding background pain that literally never leaves. Second, you have the sharp, blinding procedural pain that spikes during every single dressing change or physical therapy session. And third, there are these sudden, entirely unpredictable spikes of breakthrough pain. You've got to have a dynamic, highly adaptable plan to treat all 3 of these layers simultaneously.
But here's the really cruel irony of it all. Our absolute go-to traditional weapons against pain, opioids, they quickly lose their effectiveness here. Burn patients rapidly develop massive opioid tolerance and hyperalgesia, which means you are forced to continuously escalate the doses of drugs like morphine and fentanyl, sometimes hitting absolutely massive peak requirements around week 13 to 15, just to keep the patient somewhat comfortable. And that's all before you can even think about eventually tapering them down. Because of this whole opioid trap, you've got to deploy a massive multimodal arsenal. Yes, you use your fentanyl and morphine, but you combine them with ketamine to get that potent opioid-sparing analgesia. And honestly, most importantly, you have to strategically utilize regional anesthesia whenever it's physically possible. Slipping in a lumbar epidural or a caudal block can provide just incredible relief for lower body surgeries. And doing targeted femoral nerve blocks specifically for skin donor sites on the thighs, it's completely transformative. You have to attack the pain from multiple angles at once.
As we wrap up this explainer, I want to leave you with one final provocative thought. When you look at the sheer scale of the physiological shifts we talked about, the massive fluid requirements, the deadly pharmacological traps like succinylcholine, and this absolutely grueling marathon of pain management, ask yourself, are you just managing an immediate surgery today, or are you actually the vital guardian of this patient's entire physical and psychological recovery? Because honestly, the choices you make from the trauma bay to the sweltering OR and right into the ICU, they dictate not just if they survive, but how they survive. Thank you so much for learning with me today. Keep pushing, keep learning, and I'll see you in the next explainer.